Hey, folks. Good afternoon. Guess what time it is? It is 4 o'clock in the mountains, which means 6 o'clock on the East Coast. And it is time for Fertility with Fink and Friends. I am Fink and you are friends. And this is the place where we come together every Tuesday afternoon at 4 o'clock Mountain Time to talk about all those things that are important to us and really just to have our special time together. I have to tell you that even on days when I'm having a bad hair day, I really look forward to being here with you guys because it just feels like our own very happy, very safe place. I see some familiar names, I see some new names, and every week that we're here together, it just feels like very special time and time well spent. So thanks so much for being here. We'll be here for the next hour, and let's see if we can't get some questions answered on things related to fertility and women's health, which is what we do. I am the clinical director of IVF services here at CNY Fertility in Colorado Springs. We, of course, at CNY have offices in Sarasota, Syracuse, Buffalo, Albany. We have monitoring center in Rochester and in Atlanta and in Philadelphia and in Norfolk now. And so wherever you are, we are not far away and always looking to try to help. Great to see you folks. Jessica is the first one to be here on the Facebook side, and she is 6 weeks and 1 day pregnant today with a sweet baby from a transfer with us. That's awesome. Can't thank you all enough. Excited to see the baby tomorrow and hoping to see the heartbeat. I get that question a lot. When should we expect to see a heartbeat? Typically between 6 and 7 weeks of pregnancy, we'll expect to see a heartbeat. And once we do look and see that heartbeat, we know that 95% of pregnancies will continue on after that point. So that is probably the best milestone we can hope for. Getting that first positive pregnancy test is a very important thing, but seeing the heartbeat is really the next most wonderful step. So congratulations there, Jess. Special shout out to the Bama gal and husband. That would be my beautiful mother and father in Mobile, Alabama. Thank you for watching me today, and a hi to Staley in Miami. Hopefully she will be able to join our wonderful CNY team. First, joining up here today on my Instagram side is the beautiful and talented Allie. Thank you for being here, Allie. It's very nice to see you as always over on the CNY side. Let's see, I missed who was the first one. Giant Pens. Congratulations for being number one. You get the special prize of the day, and that is my undying admiration. Hi to Rosa and to Zeri. Chunky Mamas, Tansy. Like that one. Mrs. Anna Smith is here. AZ Sunshine. Kendra Smith, Florida Fertility Expo. Interesting. Let's see, Rebecca, looks like Rebecca Daly. Michelle with one says, hello, what's the difference between HCG, LH, and Menopur? Okay, so if you have done IVF at a different clinic, almost always you will use some FSH product, which would be Follistim or Gonal-F, and usually Menopur is the other medication. Menopur is a combination of some FSH hormone along with some of the LH hormone. And the LH hormone in Menopur is derived from HCG, which is the pregnancy hormone. So when one less expensive way to do IVF is to compensate for the FSH that's in the Menopur by taking more of the Follistim or Gonal-F and using just a little bit of the HCG LH. And that is the principal way we do it here at CNY. It makes things significantly less expensive. So, for example, an entire cycle's worth of the HCG-LH probably cost $150 maybe, as opposed to one single shot of Menopur is about $80, and that's just for one vial. Now, there may be some advantages sometimes to using Menopur, and if that's the case, then we may suggest to you, I'd like you to try Menopur, but otherwise HCG is our go-to for the LH hormone, and most people will perform just as well, but at a significantly lower cost. Hi to Steve Schmidt, Talon RN. Thoughts on Prograf with a modified natural FET. I believe that everyone should be on Prograf with an embryo transfer. Prograf is the medication that's used to prevent rejecting an embryo. So we've learned that in folks who have recurrent implantation failure, that the most common reason, or one of the more common reasons that happens, is because the body is treating the embryo as though it were an invader. So what's happening with that is that when your embryo implants inside the uterus in the endometrium, what happens is that your body thinks that that's a wound. It is quite literally. The embryo kind of goes splat into the endometrium there, and it creates a little wound. So in order for your body not to treat that like it was a splinter in your finger, we can adjust the immune system, and that's what Prograf does. And the correct dose of that is 3 milligrams a day total, which is done in one of two ways. The original studies looked at 1.5 milligrams twice a day, or at 1 milligram 3 times a day. And so that's what I recommend for all of our patients who are coming here to CMY Colorado at the time of embryo transfer. If you're not already on that dose, I like to put you on that dose, and it is showing some improvement overall in the pregnancy rates. Because do we really want to wait and see if you've got an immune problem that is going to cause recurrent implantation failure? I would rather say, well, gee, it's a common enough finding that we can turn down some of that immune response and maybe potentially be able to help everybody. It's a safe medication to take during pregnancy. You're taking it for a short term. There's a generic for it. It's dirt cheap. So that's my preference. So when we talk about a modified natural frozen embryo transfer, we're talking about, well, where does the estrogen and the progesterone come from? And that's another kind of common misconception. Folks often think, well, if I'm doing a natural cycle, that means I don't use all of those immune medications, right? Well, the truth is that the immune medications are entirely voluntary. You don't have to take them if you don't want to. We just are trying to get you pregnant, and we know that the immune system has an impact on preventing people from getting pregnant sometimes. And so that's the rationale behind it. Emily Mortensen is here, less than 4 weeks away from my twins being due. Thanks for being our wonderful IVF doctor. Emily, that is fabulous news. Oh my heavens, boy, things will change times 2 very quickly in your house. Twice the fun, but twice the diapers, just saying. Ashley and company, excited to start my first cycle this week. Just got my meds today. Outstanding, Ashley. We will keep our fingers crossed for you. Hi to Haley Dean. Special hello, of course, to Brandis, my partner here at CNY Fertility in Colorado. JM Dots, nice to see you as always. Crystal Bower says, what testing do you recommend for someone that's had multiple miscarriages, going on a 3rd retrieval and 6th transfer in 2 years, want better egg quality too? So there is a protocol of supplements for egg quality. I've actually written a book about that, The Vitamin Victory, and that is available through my Linktree, linktr.ee/RandyFinkMD. And it's a wonderful little ebook that actually even includes a discount code to be able to get if you want to purchase the supplements on the evidence-based protocol for egg quality. As far as multiple miscarriages, there is a panel that we know of as the recurrent pregnancy loss panel. And what that is that it looks for a bunch of things in your blood that are associated with the blood making little clots, tiny little clots in the tiny little blood vessels that supply the uterus and supply the placenta. If you're forming a clot in those little vessels, then you run the risk of cutting off the blood supply to the pregnancy, and that can be a cause of recurrent miscarriage. That type of condition is called a thrombophilia. Thrombo means to clot, philia means you like to, so your body likes to clot. And so we can test for those things. But in fact, in most of our immune protocol, we treat for that anyway. And that's what Lovenox is for. Lovenox is a blood thinner, and it prevents you from forming clots in those tiny little blood vessels. So even if we don't test you for it, we will treat you for it anyway. The significance of doing that recurrent pregnancy loss panel is for later on in pregnancy. So normally we will stop the Lovenox, the blood thinner, as you approach the finish the first trimester, about 12 weeks. But then the question is, well, if you've got an issue with blood clotting, then you probably should be on that medication for the rest of the pregnancy. So there's the significance of that. I do think many people believe that recurrent implantation failure is the same disease process as recurrent pregnancy loss. And so I believe, and the data supports me in this, that use of Prograf through that period of time also does seem to make a difference. As far as egg quality goes, my standard things, we think about metformin, we think about omnitrope, we think about a little estrogen and progesterone priming before starting your retrieval cycle. Let's see, Ashley Ann Lachula, Escobar Lachula, nice to see you. It's a pleasure as always. Miss Stina Face, I like it. Lindsay 84, L Mosins, LM Osins. I'm not sure how you say it. Do you have a link to the tacrolimus study during transfer? I don't off the top of my head, but I'm happy to send that to you if you'd like to message me through Instagram, and I will happily point you in the right direction of how you can find that study if you'd like to read it. Hello to Zenaida in Miami. A special good afternoon to you, my favorite payroll person. Maria King, when in a transfer cycle do you want Prograf started? So the data shows that in a medicated cycle, you start it with your progesterone start, and in a natural cycle, you would start it with your trigger shot. So it starts several days before the embryo transfer, but it does not need to be taken for the entire cycle beforehand, just within a week or so. Hi to, let's see what we got here. Liz Fisher, happy Tuesday. I'm on day 3 of a migraine. Oh man, that stinks. I'm sorry to hear that, Liz, but we're glad that you're here as well. Monique asks, what is the sedation process like for egg retrieval? So that actually reminds me, it's been, probably over a year since we had anesthesia on the show here on Fink and Friends. So I think sometime in the next few weeks, I'll ask my anesthesia buddy to come back here and talk a little bit more professionally about anesthesia. But the process is simply IV sedation. So we use some medicine that's called propofol, and that puts you to sleep. Some would call it twilight, but you're fully asleep for it, but you are not intubated, you're not on a ventilator, you're not paralyzed, you're breathing on your own. We give you a little extra oxygen and monitor every single breath that you take. But in that very safe environment, you can sleep comfortably, breathe normally, and not have to feel a thing, which is mighty nice. It's a great nap. And actually, Jessica answers back, best nap you'll ever take. And I agree with that. Not that I get to do it very often, but, hey, maybe on a slow day. It's rare that I have my own egg retrieval around here, but I won't say never, I asked for Prograf because I've had 2 miscarriages and was prescribed it, but the directions say to take it twice daily, but it's only 0.5. Should that be changed? Yes, 100%. So in the CNY system, we have always used, CNY has really kind of been at the forefront of reproductive immunology and looking at, how can we help people's immune systems that may be fighting against their pregnancy. So we have always used Prograf. It has been one of the staples of our immune protocols. But the older dose, because nobody really knew, was 0.5 milligrams twice a day. Well, in the study, they looked at, 1 milligram a day, 2 milligrams a day, 3 milligrams a day. And what they found was that the 1 milligram a day really didn't make much of a difference. 2 milligrams a day made a little bit of difference, but 3 milligrams a day made a dramatic difference in the pregnancy outcomes. And so that's where we come upon this 3 milligram a day dose that's either divided into two, so it's 1.5 milligrams twice a day, or the 1 milligram. But the problem is it only comes in a 0.5 milligram capsule and a 1 milligram capsule. So that means you have to get two prescriptions and take one of each of those things twice a day, as opposed to you can get just the 1 milligram capsule and take that 3 times a day. So yes, Liz, please increase that. I would suggest to 3 milligrams a day, or you can take 3 of those 0.5s twice a day. Tracy Allen, good afternoon. If I'm remembering correctly, I believe that you said that you will do private consults. How do we go about doing that? And how do I go about local monitoring when I can't get into places on weekends and holidays? So as far as private consults, I encourage folks to go through the CNY system, but understandably that can take a while to get appointments. On my link tree there, linktr.ee/RandyFinkMD, or you'll see it on my the bio portion of my Instagram page. There is a link for a private consult with me, which I'm happy to do as well at your convenience. As far as outside monitoring goes, and that's a very common question people ask, how do we do, how does that work at CNY? So if you look at the CNY website, and you look at traveling for care, you will see that there is a place where you can put in where you live, and it will list all the places near you that CNY has used frequently before for outside monitoring. Now, understandably, some of these places are in fact not open over the weekend, and so that is a problem and it is a concern. So what we try to be able to do there, Tracy, is to have things such that you can be monitored on a Friday and a Monday, that the weekend won't make a difference for you. What some people opt to do is they opt to come to one of our facilities as they maybe reach towards the end of their monitoring. So you can do most of your monitoring at home, but in the last few days, you plan to come to the local facility so that you can finish your monitoring here, and then you do a little less running around and less having to, expedite to get here 35 hours after you do your trigger shot. So that's always an option as well. Rosa says, I'm 42 and I have a 4.7 centimeter endometrioma on my left ovary. I will do a transfer soon. Is it better to do laparoscopy before the transfer and take the endo out, or will Orilissa be just as effective as laparoscopy? Well, if you are having symptoms, Rosa, from that large endometriosis collection in your ovary, then I'd say maybe you want to go ahead and have surgery on it to remove it. Now, we always feel very guarded about telling people to do surgery in their ovary before you do something like an egg retrieval. And why is that? Because when we scoop out some endometriosis from the ovary, it will lower your ovarian reserve. It just does, and it seems to do it really every single time. We're not as concerned about that when it comes time for egg retrieval, because we know that the endometriosis may be more of just a factor that's trying to confuse the way the brain is talking to the uterus. How does it do that? Well, it creates an inflammation in the uterine lining that now has a name. It's a protein that's known as BCL6. And we can actually test for BCL6 through a non-invasive procedure called Receptiva. I am a big fan of Receptiva because I think that is a better option than having to have a surgery to diagnose endometriosis, because in my opinion, well, let's put it this way. When we know that you have endometriosis, we want to treat you with Orilissa. And Rosa, that's what you ask about there. Why is that? Well, because 60 days of Orilissa will turn off that protein, that inflammatory protein in the uterine lining, the BCL6. So we want to be able to shut that down to improve the odds of your pregnancy implanting. The problem with doing, now, would I expect 2 months of Orilissa to have any effect on your 4.7 centimeter endometrioma? No, I don't think it will at all. That endometriosis is still really going to be there. one of the things we worry about is as it gets to be about 5 centimeters, we worry about the ovary twisting on itself, which is called a torsion. And that's something we always want to avoid. We think about that at about 5 centimeters in size. So certainly removing that endometrioma would be beneficial in decreasing your torsion risk. And the torsion risk does go up when you get pregnant. So that may be one argument there. However, I would suspect that 60 days of endometriosis or rather of suppression, is enough to turn off the BCL6, so that at least from a getting pregnant perspective, I would imagine the outcomes are really probably about the same. Now, the reason I say that even after a laparoscopy, I encourage suppression is because the classic mantra about endometriosis, and again, endometriosis is the situation where the lining of your uterus that normally sloughs off when you have a period, instead of coming out, works its way up and implants here inside the pelvis. And when it does that, it can cause a pain syndrome. It can cause fertility issues. It can lower ovarian reserve, and it can impede the way the embryo tries to implant inside the uterine lining. So the classic mantra there is the endometriosis that you see is the tip of the iceberg. So if we do a laparoscopic surgery, so we place a camera in through your belly button in order to be able to look around and try to clean up any endometriosis that is visible in the anatomy. We try to remove it, but again, what you see is just the tip of the iceberg. So if I look and I see, 3 little spots of endometriosis that I opt to treat, my suspicion is that there's probably more. And if there's more, then we run the risk of it standing in the way of your embryo from implanting. So I'm a fan, even if you've had surgery and it's found endometriosis, that maybe we consider doing suppression anyway, just to try to maximize your odds there. So hopefully that answers your question a little bit. Rosa J. Marie says, when estrogen and progesterone is used to pause your cycle, is the lining thickening? And if so, is it at least slower than usual? So what J. Marie is talking about here is that in the beginning of a cycle, sometimes there is not an available, what we'll call a stem start date. And so there's a little bit of a delay before you can start using your IVF stimulation meds. And so the easy thing to do there is that we put you on a little estrogen and a little progesterone for a few days, typically no more than 7 to 10 days, which is actually not a bad thing because it does kind of juice up the ovaries and helps to sensitize the pituitary gland to the hormones. But what it does is it literally pushes the pause button on the on the cycle, pause button on the ovary. So ovaries go, oh, stop. So maybe today was day 1 of my period, but if I start that estrogen and progesterone today, I stay at day 1 until I finish the estrogen and progesterone. So the days don't continue to count there. The ovaries stay put. Does the lining continue to thicken? The answer to that is, well, it may a little bit, but probably not anything significantly. It usually stays pretty stable because you're getting both estrogen and progesterone. And those two things balance each other out. And when they're balanced, it's really neither growing nor shedding. So basically just staying put. Let's see, is a trilaminar uterine lining necessary for an FET? This comes from Molly Moore. So trilaminar means 3 layers. And what we're looking at when we see a trilaminar lining is we're seeing the top layer, we're seeing the bottom layer, and we're seeing the interface between them. So it looks like top layer, bottom layer, and it looks like there's a layer in the middle, but it's actually just that connection between my 2 fingers here. That's a trilaminar lining. It kind of looks like Mick Jagger's lips, is what some people will say. That is a sign of adequately estrogenized endometrium. So that's a good thing. It tells me that, the lining has been a perfect recipient of the hormone and is where it needs to be. The fact that it's trilaminar is probably more important than its width. So some people have a little thinner lining, like we like it to be about 7, maybe it's 6, but it's trilaminar. That's more important. But what if it's 8 or 9 or 10, so it's a good width, but it doesn't show that trilaminar lining. Instead, it would be what's called heterogeneous. So it's kind of just looks like a bunch of different stuff in there, a bunch of different sort of sonogram looking images, black and white. I usually what that means is that you need a little bit more estrogen. I don't stop an FET from happening because the lining does not appear trilaminar. There are some other things that we can do to look at the lining to see that it's looking good, looking at the blood flow, looking at its thickness. So I won't pull the plug on a cycle because the lining is not trilaminar. But if you're doing a medicated cycle and you're taking your estrogen and you're reach the point that would otherwise be your progesterone start, and that lining is thick enough, but it's not trilaminar, typically that tells me you need about probably 3 more days of estrogen. So that's kind of the way I do that there. Let's hop back over to the Facebook side here. I have an appointment coming up. Should I do all the labs before my consultation appointment? Well, if you can, it certainly saves some time because then we're able to look at those lab tests when we have you on the phone. Particularly the one that's really the most important is called the AMH, the anti-Mullerian hormone, and that is a measurement of your ovarian reserve. And so when we decide on medications, on what we're going to use to treat you or to stimulate your ovaries, that dosing is based first on your age and secondly on your AMH. And so if we have that information, it just helps us. So it's nice to have that ahead of time. So I would say yes, if you can. Do you suggest Theralogics vitamins for men and women? They are fine. I actually like Molecular Fertility's vitamins, molecularfertility.com. So as far as a prenatal goes, that is a really excellent one. Sally is asking, can you do an ERA out of country? And if yet, what do the doctors need? And if yes, what do the doctors need to perform it? So I will tell you, Sally, I believe in Trinidad. Am I right? An ERA is really no longer considered to be a very meaningful test. And so it is a rare day that I will tell someone that you should do it. Now, it's still very popular on the internet. It's very popular on the Facebook pages. People say, well, I did my ERA, and that's when I finally got pregnant. But the data shows us that the difference in timing found from an ERA really doesn't affect the pregnancy outcomes. It doesn't affect the birth rates. All of us can tell you a story about someone who failed transfer, finally did an ERA, found out that the timing was off, and then lo and behold, changed the timing, they got pregnant. But in reality, when they look at tens of thousands of cycles, it doesn't make any difference in the grander scheme of things. And so it's an expensive test. I don't recommend it. I don't think it gives us meaningful information. And the data supports that as well. So despite what you hear, there may be some occasion when it's useful, but by and large, it used to be a standard part of our kind of workup when things weren't going the way they're supposed to. Nowadays, really pretty rare. But you need the kit. Basically, there's a special little vial that the tissue goes in. Otherwise, it's just an endometrial biopsy that's done at a specific time during the cycle. Laura Lou says, why don't you dual trigger with Clomid? And in a Clomid and letrozole protocol, why don't you do a dual trigger? There's probably some real scientific answer to that. So in one of our low dose protocols for folks who have a diminished ovarian reserve is based on a low dose of FSH hormone like Gonal-F and using both Clomid and letrozole every single day during the stimulation from stim day 1 until the day of trigger. But that protocol uses just an HCG trigger. Again, there probably is some deep, dark endocrine answer to that, but the real answer is because that's what was studied when that particular protocol was demonstrated for people with very low ovarian reserve, and how it turned out to be much more successful than some standard type of protocols. It was with an HCG only trigger, so kind of use what the data shows works. But that was a good question. Hey to JM Dots, what are your thoughts about the usefulness of biome testing, like fertility? At this point, and so another test for that is the Emma and Alice test, which comes from it comes with the ERA. So the ERA was called the endometrio, the three tests, the ERA, the Emma, and the Alice. I have yet to see data that says that the vaginal or uterine microbiome has an alterable impact on pregnancy. So it doesn't have a meaningful impact. I'm pretty sure it probably does, because I think we don't pay enough attention to the bacteria that lives within us in all these different places. But you can do the test, which gives you this whole sort of breakdown of what bacteria you have and what type of lactobacilli is there or not there, but then at the end of the day, the recommendation, okay, well, all right, so I'm broken, how do I fix me? And the answer is, oh, you take a probiotic. Really? That's the answer? I did this $900 test so you can tell me to take a probiotic? Probiotics are good things. I think they do a lot more than they're given credit for, as far as altering our microbiomes. I think that is a ripe area for research, and I think it will be studied much more thoroughly, kind of going down the line. But just because it's an available test and kind of because it's cool to know the answer, doesn't yet tell me, okay, how do we use that information to fix you? It's not at the point where we have some result that we say, okay, well, this is going to cause first trimester miscarriages, so we need to alter some ratio of bacteria in your system. If we just do that, we'll never see more miscarriages. It's not at the point where we have meaningful information to be able to use for specific treatment options. But is it interesting? Yeah, absolutely, it's interesting. Ludi asks, how early should you order your meds for cycle day 1? I like you to have meds in hand about 2 weeks before you intend to use them. Let's see what else we got here. Zahida Christie. Good evening, Duncan. Good evening to you. I'm 46 and want to have another child. I had a bilateral tubal ligation. All right, so having had a tubal ligation means that sperm and egg will not be able to meet each other in the normal way, and that IVF is really your only option. The problem that we will run into is that at 46, we have a very, very low success rate from IVF. And why is that? Well, the eggs in your ovaries there have been in the ovaries for the last 46 plus years. And over time, the DNA in those eggs becomes less stable. Even in nature, it's harder for us to have a baby as we mature. And we also have, there are fewer eggs, and the quality of the DNA is not as good. So it's definitely an uphill battle. At 46, CNY will not turn folks away. Most clinics would tell you, absolutely not. We will not try this with your own egg. We will only do this if you will use donor egg. Okay, understood, because they want to be able to show success. If, Zahida, you were to use a donor egg, then you'd have a very, very high probability of getting pregnant. With your own egg, it would be definitely an uphill battle. But again, is it worth a try? I think it's definitely worth giving it let's take a look at your numbers and let's see, get some meaningful statistics back so you know what you're getting into. But we do not turn folks away based on age, based on weight, based on AMH. Everyone deserves their try. Rebecca Daly says, "Do you you don't do embryo transfers in Philadelphia, right?" That's correct. So the Philadelphia office is not a full service embryology center. It just does monitoring at this time. Um, Kaler, Alicia says, "I'll see you Thursday morning for my retrieval." Outstanding, and I am working. Am I working this Thursday morning? I may be working Saturday this week, so I may not be here on Thursday morning. Can Oralissa cause permanent menopause with a low AMH at 42? No. Oralissa is a suppression medicine, just like Lupron would be, which Lupron overtly does cause a temporary menopause, but this is a reversible effect, and it is not said to be permanent. Your favorite AVP says, "Hello, doctor. Does being on suppression meds for more than a week before starting stims ruin the cycle?" So when you say suppression meds, maybe you mean like on birth control or on some estrogen and progesterone. No, there are some places that will prime you even with that, sometimes even for a few months. And that's okay. In my opinion, I don't like to do it for that long. I like 7 to 10 days. I think you get a really good result from that without having to worry about turning down the volume knob up there in the hormone center. But no, it's certainly, but when you talk about suppression, I think about, for endometriosis, um, does that ruin a cycle? I believe you must be talking about the estrogen and progesterone. No, it does not ruin a cycle. Hello to IVF newbie Steph. I'm going for my first egg retrieval on Friday at CNY Sarasota. They have been so wonderful there, and it's a beautiful location too, full of very, very nice people who work there. Best of luck there, Steph. Our thoughts will be with you on Friday. How long before transfer should I start L-arginine, and how much of it daily? So L-arginine is one of those things that is part of the 5-supplement protocol for embryo transfer: prenatal, vitamin C, vitamin D, vitamin E, and L-arginine. I would start it, you can start it as soon as you know that you're going to be doing an embryo transfer. But at the very least, at the kind of on cycle day 1 is when I would stop that. B. Washe says, "When is it okay to announce a pregnancy?" That's a tough call, and I have my own opinions on that, having practiced obstetrics for a couple of decades. I will tell you that I believe, we used to tell people, don't say anything to anybody until after, until 12 weeks. And why is that? Well, because the risk of spontaneous miscarriage drops down very significantly to about 1% after the 12-week mark. So, if you make it that far, then you're probably not going to miscarry. Well, what we know now is that when we look and we see the heartbeat, again, as I mentioned before, 95% of those pregnancies will continue on, will continue growing. So, it's basically a 95% by the time you see the heartbeat versus a 99% by the time you're at 12 weeks. Sometimes it gets very hard to keep that information to yourself when you really want to tell people and let people celebrate the joy with you and share in your own ups and downs. There are a lot of folks, I've seen, and I believe, my personal opinion, mistakenly so, from the moment they have a positive pregnancy test, they're posting it on all the social media. They're telling all their friends. They're making sure that every neighbor and relative, distant and otherwise, know about it. And, from the time of that first positive pregnancy test, there's a lot of things that can happen. And I suppose it depends on how you personally feel about it. My own feeling is that I'd kind of like to stay, keep my personal things personal until I'm ready for them not to be. And if you share the news early, then everyone is going to keep asking you about it, and that's the downside. Let's see. Kelsey says, if your periods are longer than 35 to 40 days postpartum, is it still okay to do a medicated transfer? So yes, Kelsey, if you're doing a medicated frozen embryo transfer, then what's happening is that we are controlling all that timing. We're controlling all those hormones. And so your normal cycle days don't become relevant because we're basically covering them up with the hormone that we're giving you. So we are superseding the body's ability to make those hormones so that we can control every variable. So yes, even if you don't have let's say your periods are once every 60 days or once every 90 days, or you get a period once every 6 months, it's all the more reason to do a medicated cycle, because then we can control all those variables and get you pregnant in a very predictable kind of way, as opposed to trying to rely on your body to make those hormones, which it doesn't, clearly probably doesn't do on as predictable a level. Lindsay says, excited for our second transfer this July in Colorado, and we are excited for you. If I had an allergic reaction to the trigger shot during the egg retrieval, would I use something different for the transfer since we're using a modified natural? Well, I'd want to know a little more about what you mean by an allergic reaction, because it may have just been a little sensitivity to something preservative or something, not truly an allergy. But if there's any question of that, then yeah, there are certainly other things that we can use for trigger. Jessica says, excited to see you next week for an egg retrieval, and we are excited for you, Jessica. Make sure that you say, I said hi to you on your live. By the way, I love that. I love that. I love it when people say that they actually get something from this time we get to spend together, and I really do appreciate it. In fact, a little story to tell you. First thing, 42 minutes after the hour, by the way, we'll be here for about another 20 minutes or a little bit more. Fertility with Fink Friends, live from Colorado Springs. I am Fink. You are friends. Absolutely. What was I going to say now? Oh, something of critical importance. I talked to a very lovely lady today who said, do you remember a couple of weeks ago I asked about, we're doing a timed intercourse cycle, and I told you that I had lost my left tube, but my follicles were over there on the left side. So can I still get pregnant? And I said, why, yes, you can. And I showed a little visual with my friendly neighborhood uterus, which when standing kind of sits like this, and the ovaries are kind of sitting way down. They're sitting kind of low. Down here is really where they are anatomically. And I said, yeah, if you're missing a tube, it really doesn't have a huge impact on your fertility, because even if you release an egg from, let's say, from that side, and you're missing that tube, it can just as easily make its way into that tube right there. And so in this conversation I had with her today, she said, and you were exactly right, because she got pregnant. And so I love that when that happens. Occasionally it does happen, and I want to make sure that everyone, especially Brandis, knows that occasionally I am right. Okay. Let's see. Hey to Gabby Thorpe. Nice to see you. Shabnam, good to see you this afternoon. I transferred 2 frozen embryos yesterday. When the embryologist checked the catheter tip under the microscope, they found that the embryo was still in the catheter. Can you explain? Yes. So embryos are good, sticky things, and they are placed in that little syringe with something called embryo glue. So that makes them even stickier. And when we place the embryo into the uterine cavity, we always go back and look to make sure that the embryo went with you and didn't stay with us. So it is not uncommon to have a retained embryo still in the catheter. That's the very reason they go back and look. It does not change the outcomes at all. It doesn't change fertility rate, pregnancy rate, live birth rate, or anything else, so you don't have to worry there. But they just, they're sticky, and just like they want to stick in you, they like us when we're making them, so they sometimes want to try to stay with us. So we look, and then we just basically set you back up and place the catheter back in, do the transfer. Again, see the little spot by the ultrasound. They go look under the microscope, and confirm that you got your embryo. An important thing that I always tell folks after an embryo transfer is that you will see vaginal discharge because we clean off the cervix. We use use some fluid. You've been putting some progesterone in there. The cervix itself makes a lot of mucus. So despite the fact that your husband may be driving and you're a little iffy about his driving, you can't bounce an embryo out in the car. You can't take a sharp turn and make it come out. You can't pee it out. You can't poop it out. You can't sneeze it out. You can't blow it out when you blow your nose. They're good and sticky. They're not falling out on their own. But because they're so sticky, sometimes they like to stay in the syringe. So no worries there. Hi, Nurtured Shanna. Can you please say more about the estrogen and progesterone priming before retrieval? What I like to do with priming is that I like to use estradiol, which is just an estrogen pill, twice a day for 10 days, generally starting on cycle day 21 of the cycle prior to the onset of your stimulation. So that's called luteal phase priming. We do that every day with some Provera or some form of progesterone. Since Provera can be used as an antagonist or as a medication that stops you from ovulating, what I like to do is that if we're not planning to do a fresh transfer, because when we're planning to do a fresh transfer, we can't use the Provera medication. We have to use the shot, the Cetrotide or the Ganirelix. If we are not planning a fresh transfer, then we can, then I'd say you do your estradiol twice a day for 10 days from cycle day 21 in the month before. You take your Provera every single day, and you just stay on it until the morning of your trigger shot in your cycle. And so then that makes it a very elegant way. It prevents you from ovulating. It's dirt cheap. It's one less shot. And people do very, very well with it. But the purpose of that estrogen, remember that estrogen and progesterone are the language that your ovaries speak. And so by speaking to them in their native tongue, what we're able to do is to increase some of the blood flow that goes to the ovaries. We're able to sort of tune up the pituitary gland that's going to be receiving the signal from the stimulation meds and then sending the signal to the ovaries. So that's kind of what priming does. And again, I like to do it just in the 10 days, the last 10 days of the cycle before you start. The other advantage to that is that when we do it that way, we know that from cycle day 21 of the cycle before you get your period, cycle day 21 of the cycle before you start your stimulation, that 10 plus however many days later, I like to do it 3 or 4 days later, you're going to start your stim meds. So if we do it that way, then we can put your stim start date on the calendar a couple of weeks beforehand. So you'll know exactly when you're starting. You don't get delayed at the beginning of your cycle because the stim start schedule is filled, and just kind of an elegant way to sort of address a bunch of problems there. Can having to reschedule a medicated FET 4 days later cause a failure? They were booked on 6/7 and moved to 6/11 with a day 3 8 cell. So you were on a medicated cycle. So in a medicated cycle, this comes from Escobar, the estrogen amount or the number of days that you get estrogen is variable. You can go 4 days, you can go 6 days, you can go 12 days, you can go 21 days, even if you need to. The only thing that's fixed there is going to be the amount of progesterone. So we take the time of the transfer and we count back, and that's how we know when the progesterone start is. That one is fixed, but the estrogen amount can be variable, so that does not have a negative effect on your FET. Let's see, is it normal not to feel anything post-transfer? I'd say that's completely normal because, what went into you are just a few cells, and until they take a hold and start to really make some changes in your hormones, you probably won't really tell very much. What's the first thing? Anybody know? Listen, I'm talking to you like you're going to be able to answer. Raise your hand, please. What's the first thing? What's one of the first, really, in most people, the first sign of pregnancy? Anybody know? Again, I'm expecting you to answer. It's breast changes. So it's usually breast tenderness, and it's often overlooked because many people get breast tenderness right before they get their period. So they start getting like really sore and they say, oh man, it must just be because I'm going to get my period. But it is a different soreness. It's a lot more nipple sensitivity, larger breast, bloated breasts is the way I describe it. And they have a particular kind of feel that sometimes you can tell if you touch them. That's usually the first sign. People say, well, I thought I would be getting nauseated right away. Nausea in pregnancy, which is, believe it or not, said to be a positive prognostic sign of pregnancy, usually doesn't actually begin until about average is between closer to 7 weeks of pregnancy. So usually that's not something that happens in the very beginning. It can, but typically a little later on after 6 weeks. Why do chances of success increase with back-to-back euploid transfers? Well, because every one euploid embryo has our highest probability of success. So when you transfer your first euploid embryo, that embryo has a 65% chance of pregnancy. Since each euploid has such a high chance, if that first one doesn't work, then when you add the second one, when you go back to do a transfer of euploid embryo number 2, you are at an 88% probability of pregnancy. And if that one doesn't work, by the time you do euploid embryo number 3, you're at a 95% probability of pregnancy. So another way to kind of think about that is that, well, all right, if it's 65% for the first embryo, wouldn't make sense. It doesn't make sense to say, well, the second embryo is also 65% probability of pregnancy, because then we'd be at 130% probability of being pregnancy. Where do you get an extra 30% above 100? And there's really nothing that's going to be 100%. So since they're not exactly additive, that's sort of the way the statistics bear out. 65%, 88%, 95%. But that's a really good question. If Nicole asks, if I'm only using vaginal progesterone, how do we ensure that my progesterone is high enough to carry a pregnancy? Well, Nicole, so if you're doing a medicated cycle embryo transfer, then you should be using progesterone in oil. There's some people that say, I don't like to do that shot. I don't want to do that shot. I shouldn't. I don't know. I'm not going to do that shot. That's your choice. But the outcomes without using progesterone in oil in a medicated cycle embryo transfer are abominable. They're terrible. I would tell you that you're really probably wasting an embryo by not using PIO if you're doing a medicated cycle. If you have an aversion to doing the progesterone in oil shot, and I don't blame you a bit because it is no fun, then do a natural or a modified natural, because then you don't have to use the progesterone in oil. What's happening there is that your body is making most of the progesterone. And it comes from when you ovulate, your ovary releases an egg. That space that's left behind is called the corpus luteum, and that's where your progesterone comes from. So if your body's making it, you don't have to have the shot. In that scenario, we just use a little vaginal progesterone as a local effect. So it really just treats the uterine lining. It helps to make that lining more progestational or more pro-pregnancy, but it is not measured in the blood. So what's going in vaginally only has an effect. It would be similar to kind of putting hand cream on your hands. Makes your hands nice and moist and smooth, but you don't get hand cream levels when you check your blood test, right? So that's what happens there. When we do a blood test in a natural or a modified natural cycle, we're measuring the amount of progesterone that your ovary is making. So that's kind of how that works. Hopefully that makes sense. Hello to Elaine. Oh, actually, Doc Sherry says, thanks so much for doing a great job on my egg retrieval last Wednesday. Thank you. Thank you for saying so. I appreciate that very much. Elaine says, I want to thank you so much for being my doctor. Oh, gosh, this is what a day this is. Boy, everybody's got nice things to say to me. It doesn't happen very often, so you can't imagine how much I appreciate it. May 17th, you did my transfer, and I'm finally pregnant after a 5-year journey. God bless you for all you do for families trying to have a baby. Thank you so much. Boy, that is really that, Elaine, that's a beautiful thing to say, and I am truly appreciative of those kind sentiments. Thanks so much. I tried low-dose naltrexone at bedtime and it gave me insomnia. Can I take it at the evenings instead of bedtime? Yeah, yes, you may. Some people get have weird dreams from low-dose naltrexone, or some people it makes sleepy. If it gave you insomnia, it's the opposite effect. So, I mean, you can try it out and see how you feel during the daytime with it as well. Maybe it's better for you to take it in the morning. And I think if that's the way it is for you, then that is okay. It won't harm a thing. Let's see. Jenny says, I have my retrieval at Colorado Springs on Thursday morning. I have 1 follicle and 1 cyst. What are my odds? What would it be better to cancel and try again next cycle? They think the cyst might have an egg. Well, if you've got a couple of follicles, so Jenny, a lot of that depends kind of on what your numbers look like, the ovarian reserve, on what your stimulation was like, how you responded, and so forth. But if there's a couple of follicles there, I would say, I'd say do it, for sure. I have to tell you, if, CNY is pretty good. If you do a retrieval and you don't get an egg, Dr. Kiltz is very good about significantly discounting another cycle for you. So you are not sort of left holding the bag there. He is very generous in that regard. Okay, Amanda says, I finally made a live. Outstanding. I had my first egg retrieval, which resulted in no euploids. Does that give insight into my next one, or are they independent of each other? Well, they definitely are independent statistical events, but I think it depends on, some of that depends on where your ovarian reserve numbers are and what you're doing to try to improve egg quality. So when I look at a cycle, oftentimes we'll have a consult with somebody and we'll look and say, all right, well, I see here that the issue was purely egg quality. So we are going to throw everything we can at trying to get you to make better eggs. Because it may be, I don't need you to make, 40 eggs in order to get, embryos to get pregnant with here. If we dial down the stimulation, sometimes we'll get fewer eggs, but we get better quality. I also think about things like growth hormone. I think about things like metformin and the supplements that we use for egg quality. So really, Amanda, I would want to make absolutely sure that we're doing everything we can for egg quality. And I think you can likely expect a difference, because here's a question for you to ponder. Does everyone have at least one normal egg in their ovary? And I think the answer is probably so. If you're menopausal, you don't have any eggs anymore. But if as long as you've got eggs, the odds are there probably is one that's normal in there. The question is, well, how much stimulation are we going to have to do? How many cycles are we going to have to do? What are we going to have to do to try to get you to get that egg? So, yeah, Amanda, I do think you got something in there, and it's a question of maybe changing things around a little bit to reach that happy place. We got a couple more minutes here, so let's see. Try to get a question I can answer in a hurry. Can I get pregnant with an IUI after fertility meds? Why, yes, you absolutely can. And let's see, Steffi from KC says, you did my retrieval a couple weeks ago, got more eggs than expected. Unfortunately, none fertilized. Thoughts on calcium ionophore? 30 with a high FSH, low AMH, but normal cycles. Calcium ionophore is a laboratory chemical that can be used in folks who have no fertilization. That is the indication for it. A lot of times people will read about that and say, well, that's what I want to do because I think it's, I want to try everything and I think that's going to improve. If you fertilize an egg, it doesn't improve anything. It may actually hurt things, but potentially, Steffi, yes. I think it also may be a question of egg quality, but calcium ionophore is indicated in situations where you have eggs, but none of them fertilized. So hopefully that helps. Can you believe the whole hour has ripped on by as fast as it has? Boy, it is such a pleasure to be here with you every Tuesday, and I truly appreciate all the kind words that you send, not just to me, but to all of us here in the system. I saw a very meaningful Instagram post that came from my friend Mrs. Vence, and I meant to take a picture of it so that I could read it out and shout her out for saying such a beautiful sentiment. But now, of course, I'm not going to be able to get the words right. But shout out to those who can still be nice and show kindness to all other people at every opportunity they can, even when it seems like your own life sucks. Because that is what makes us a special species. Because life does suck sometimes, and the sign on the wall behind me is the mantra: every step forward with kindness, every step forward with love. And remember, there is absolutely hope for a new tomorrow, because this is not the book of your life. This fertility business is just a chapter. And what we're here to do is to rewrite that each and every single day together. Thanks so much for being here. So until next Tuesday, I'm Dr. Randy Fink, live from Colorado Springs. Good night.